Yeah, MRSA is an epidemic in America. MRSA is methicillin-resistant Staphylococcus aureus. It's a staph infection that's resistant to normal antibiotic control, and for some reason, and I don't know the reason. I've tried to figure it out. America is different from other countries or some other countries, such as the United Kingdom, in terms of MRSA control. The big difference is, okay, how do infections get into hospitals? Well, very often patients bring them in. But with MRSA, it's standard procedure in the United Kingdom that when a patient comes in, gets a brief nasal swab, that's cultured to see if the patient has MRSA. The patient may not be infected, he may just have colonized MRSA germs. But there are treatments for that. Maybe you can, or maybe the staff can treat the MRSA. If not, the patient can be isolated. And then there are important infectious barriers, controls that can be implemented. MRSA patients stay with other MRSA patients or completely isolated. Doctors and nurses who deal with them use disposable paper gowns and masks. They use them one time. In other countries, again, United Kingdom, Holland, I believe Denmark, where they do this, MRSA is a very small percentage of staph infections. In this country, it's over 50%. So I don't know why we don't do that, but we don't. We should. You have a right when you go into a hospital to see the history of the room and the room cleaning, okay? I would advise people, if they possibly can, not to go into a room, wait for another room, but not to go into a room where the last occupant had MRSA or Clostridium difficile, sometimes called C. diff, or VRE, I think that's vancomycin resistant enterococcus, which is a gut infection. You don't want to. It raises your chances enormously of getting that illness. You also want to see the room record will show you whether all high-touch surfaces, such as the light switches, the toilet handle, the areas around the bed, have been properly cleaned. Now, proper cleaning is a big issue in hospitals because it costs money. It should be inspected with something with maybe some type of illuminometer, which lights up bacteria, microbes. In addition, there are methods out there, but they're expensive. And some hospitals sort of go halfway with it. They may have one or two ultraviolet ray zapping machines that go into a room, zap all the surfaces, kill the MRSA, kill everything, okay? Or you mentioned hydrogen peroxide. There are hydrogen peroxide foggers, do the same thing. Take some time. They are relatively expensive. A UV zapper, I think the last time I looked, cost about $70,000. Now that's more expensive than the hydrogen peroxide fogger, but the hydrogen peroxide fogger takes more time. So time is money, and that's especially true in healthcare. But I mean, we have these methodologies. They're called no-touch disinfection. You should have them for rooms, especially rooms where people have had infections. I would say you should have them for rooms where people are most vulnerable, like ICUs, intensive care units. I mean, hospitals, unfortunately, they're more inclined today to spend money on fancy therapeutic technologies, robotics, hospitality elements, things of that nature, which sell the hospital. Cleaning doesn't sell the hospital. Another thing that should happen is that hospitals should compete and be graded on their infection rates. They are not. You won't find out. It's very difficult to find out. Now, if you go to a surgeon, if you're going to go in and have a procedure, he or she should tell you his rate of infection. And I would certainly urge everyone to find that out. One of the things that we've also learned since this flurry of news and media attention in the late 90s, or in the late 20th century, the 80s and 90s, is that experience matters. It matters critically. And if you're going to have, whether it's a knee surgery or a hip surgery, heart bypass, whatever you're going to have done in the hospital, if you have the chance to plan, you should find out the experience level of whomever is performing it. And there are excellent studies that show that the more experience the surgeon has, the better your likely outcome is. And it can be for very sophisticated surgery, pancreatic surgery, or it can be for common knee surgery. But it's very, very important to understand the experience of that surgeon. I just can't underscore that enough. Well, that's a real issue and it's a real problem. I mean, I think it's about a quarter of the time in some hospital systems that there's a language barrier, for example. That's a problem. A lot of times you're dealing with patients who may not be, or they may be demented, or they might be post-trauma or something like that. So it's a very difficult situation. Yes, people should, to the extent possible, be knowledgeable. In the internet era, about 2/3 of people actually will do research, they found, on what doctors tell them about their diagnosis and the drugs that they're supposed to take. And that's a good thing. That's a good thing. Now, you can sometimes, not do a good job and have some faulty ideas, but it's generally a very good thing. It's also a good thing to go into a hospital with a family member, with an advocate, if you possibly can. But that's not available to a lot of people, unfortunately. Everybody talks about minimally invasive surgery. It could be for back. I mean, we see a lot of advertisements for that. It could be laparoscopic for gallbladder or what have you. Generally, it's better. Generally, it's better if you to have I'd say the least surgery possible, and then when you have surgery, you have the least invasive surgery. Average American has 9 surgeries in a lifetime. That's a lot.